So I'm Lawana. I'm one of the faculty members here at Regis College. I work in the nurse practitioner program here at Regis. So I'll let you introduce yourself for those who will be listening when we put this on the website.
Okay. You ready for me now?
Sure.
Okay. So I'm Tanya Henry. I work at the Columbia VA healthcare system here in Columbia, South Carolina. I'm actually one of the nurse managers. I oversee the acute care area, which includes the specialty areas, cardiology, dermatology, endocrinology, rheumatology. I also oversee derm and neurology. I'm also, since COVID started, what is it, about a year and a half ago now?
Yeah, almost 2.
Yeah, almost 2 years now. I've also been the manager who provides oversight to the COVID operations here at our facility.
Well, it sounds like you are a busy lady. So we're glad that we had a few minutes to talk with you today. I'll tell you that we're both in Columbia. So that was one of the reasons when we saw you as one of the nurses that Johnson & Johnson recognized. I'm like, oh, we definitely have to talk to somebody from Columbia because in my other life, I work in the University Health Clinic for USC, seeing women in the women's care clinic there at University Health. And I've been there for 6 years. So I know about the VA, which we affectionately call Dorn here. We just all kind of shorten it. You know, nobody says the VA hospital. I don't think anybody probably knows the whole name. Everybody just says Dorn because we all know it's been a presence here. And then, of course, the university has an affiliation with Dorn because of the School of Medicine, because our medical residents and all are there. So, yeah.
We have a lot of them that come through, whether it's nursing students or the physicians that are, or the fellows that are coming through to get some of their experience here at our site. So I can honestly say they love it. So
yeah, we do. And we're glad, you know, because it's a great resource for them and a great place to learn, you know, a very great place to learn there and to be able to serve the population of veterans, which is appropriate since today is Veterans Day that we're recording this. So it definitely provides a wonderful service to those who have given a lot, you know, in their life of service. So that's great. So I have to ask you, and which I ask every nurse, and this is my only selfish question in the whole process, and it's just out of my nature, you know, as Southern people, when we meet somebody, we need to know, you know, where you came from, all that kind of thing. So what my thought is just to know, how did you get to be a nurse? Was it a lifelong ambition, or did you just kind of come to it a different way? Because I'll tell you, the answer always varies. So how did you get to be Tanya RN?
Well, you know, to be honest with you, as young as I can remember, I know that I was always intrigued with medicine, you know, growing up. And I remember growing up, I always wanted to either be a teacher or I wanted to be a nurse. And I do come from a family who a lot of the females in the family are nurses. But even outside of that, my father's side is business. So it was funny because as I got older, the whole education teacher part dropped off in the sense of, you know, like in, you know, teaching school age or in, you know, the school system. But the nursing just stuck with me. And honestly, I don't even see myself doing anything other than that. So growing up in kind of a nursing business background, going through school, my dad, you know, he instilled, well, you still got to have some business in you. When I went to nursing school, I actually did a business minor, and I actually was born in New York, but grew up in California.
Oh, wow.
And I moved I moved to South Carolina in 2008. And even coming to the VA, I did so many clinicals at the VA out in California, and I never knew I was going to work. I never really knew I was going to work for the VA because I had done so many clinicals. I said, no, I want to go into the private sector. I want to do labor and delivery. I want to do all this stuff. Back then, when I graduated in 1998, you couldn't do that. You had to have like a med surg background before you could get into those specialty areas. So the VA had called me probably about 2 or 3 times, and I honestly turned them down. You know, and then finally I went, and history speaks. And today, like I said, I am a nurse of 23 years now. Came straight out of high school, went to California State University. And here I am in South Carolina being a nurse, and I absolutely love it.
Oh, that's amazing. That's wonderful. And that's another kind of connection we have, because I actually I graduated from nursing school in 2006. So I went back at 36, I went back and revisited the degree I was supposed to get at 17. So I was one of those people that had to go do it the hard way. But my first 10 years were spent as a night shift nurse in labor and delivery. So I did, yep. So I did labor and delivery night shift, because at that time you didn't have to, you could go straight into the specialty area and be trained. So so we've evolved and changed a lot. So I will tell you though, I love nursing, but one of the things I have always said as a nurse was that I'll be a nurse, I'll work hard, but I don't want to be a manager. Mm-hmm. So how did you step into that role? Because that's a whole nother level of nursing when you're the nurse manager.
I will be honest, as far as being a nurse manager or in that leadership role, starting out in nursing, it is not something that I really saw or even thought about, honestly. And my whole leadership journey actually started when I was in high school, and I say that because, I was that person where you just go, you just lead by example. But that was just naturally my personality, just naturally. So I remember back in high school, a lot of my friends, a lot of, some of my instructors, they wanted me to run for class president. I said, really? Honestly, class president? Okay, fine. I'll run for class president. And I got it. Okay, I actually got it. And being up against these different individuals, I'm like, how sometimes people see things in you that you don't see in yourself.
Right. Mm-hmm.
So my focus that was like my turning point, that senior year of high school, not even realizing that people saw me as a leader. Mm-hmm. I enjoyed being a leader, and I just moved forward. So when I went into nursing school, within my first 6 months being on the floor, and I actually started out, in the VA, but I started nursing as they called it back then, a student nurse tech. Yeah. Because I had not taken my boards yet.
Mm-hmm. So, me too.
Okay, so you understand that. Mm-hmm. And so it was I started the September, and then the end of October is when I took my boards and passed, of course, so became officially an RN. And within 6 months, they put me in the charge nurse role.
Wow.
And I was like, okay, I'll try it. And I'll be honest with you, back then I was obviously one of the youngest ones. Mm-hmm. And it was tough. It was everything you could think of that would make it hard, whether it was name calling, whether it was they just wanted to go against what I was, scheduling, whatever it was mm-hmm. just difficult, but I never gave up on it. And then just, putting myself in their shoes and letting them understand, look, I'm not trying to step on any toes. I'm just trying to we took the same boards. Mm-hmm. I'm just here in a role, just, teach me how to be the leader that you want to be.
Exactly. Exactly.
And so walking in those footsteps in that charge nurse role, and that would have been 98. I started to just master it and just became comfortable with it. But again, it was just something natural within me. Just mm-hmm. I didn't try to be the leader. I was just mm-hmm. people say a born leader. Okay. Mm-hmm. Okay. I accept that. So, 2000, so that was 98. So 2005 now, here it came again, a nurse manager position came open on this unit I was still working on, which was a med-surg unit, a med-surg telemetry unit at the time. And again, I was working night shift at the time. I was still a bedside nurse, working 12-hour night shift nurse. Nurse, and my nurse manager at the time called me. I can remember it speaking to you right now, 2:00 in the morning.
Wow.
She was like, Tanya, have you ever considered applying for the nurse manager position? And being a nurse manager position of the unit, I was already a staff nurse on. So, mm-hmm. That took a lot for me to even decide to do, because I'm like, okay, I've been these colleagues for these last 6 or 7 years. And now you want me to change roles with them and now direct them, lead them. discipline them, evaluate them. And I said, okay. So I went for the challenge, interviewed about 2 or 3 times, different levels of interviewing, and I got it. And after I did that, assuming I guess I did a good job, they started piling on other responsibilities. So I had ended up managing 2 different departments at the same time, and just mastered the leadership as I went along. And then, at that point now I was like, okay, this is something that I'm really enjoying. This is something where you feel like you're making a difference. And one thing that honestly has just guided me from 2005 to today, when I came into that true leadership role, is I have always been one of those individuals where I put myself in the shoes of my employees. I tell my employees that the title behind my name, we're all RNs, or we're all nurses. We have LPNs, RNs, CNAs. The nurse manager role behind, that's just a title. That's just my job assignment. But at the end of the day, I'm still a nurse just like you. So I put myself in the trenches. I get on the floor with them if I need to. Open door policy. What is it that you need? Solicit feedback from them. And that has honestly just carried me along the way to this day. Even with COVID operations, I'm out there in the trenches with them if I need to be, and, just being that servant leader for them and listening to them, communicating with them, meeting their needs. Because when you have like 80 plus or 50 plus, whatever it is, different employees or personalities under your belt that you're responsible for, I mean, you have to speak with them, address them all 50 different ways, and I've just been able to do that. And,
that is just amazing. I mean, I love the fact that and I do believe that there are qualities we have that we are born with, and we kind of, you get in that zone and they realize, hey, you're good at doing this, because, as managers, and one of the reasons I kind of shied away from it was you walk in a tightrope kind of, and the staff has one end of the rope and the administration has the other end of the rope, and you have the little patient there in your hands trying to get across and manage everything,
But and the biggest thing with that, and you're right when you say that, because you have the administrative, you have the policies, and you have the employee side. But the key is getting that buy-in and letting them understand why we do what we do. And that myself as a manager or a leader is not above what we're doing, what you're being asked to do, and if you can get them to truly understand that and get the buy-in and, be compassionate with them, be understanding, get their pay right.
Yes. Oh, please, because we need to check. Okay.
Get their pay right and give them the feedback that they need. That's what makes you a good manager.
Right.
They'll laugh at me now because they're like, Tanya, why don't you ever have any openings? And I'm like,
because people want to stay.
They want to stay.
Yeah, they want to work for a good nurse manager. Definitely.
And you know how the saying goes that people will leave a position or a facility or a job not because they don't like what they're doing, but a lot of times they leave because of the leader.
Yeah. And that makes such a big difference. I've had a couple of female nurse managers that were just, like you said, servants. I mean, I think the difference for me was that I would have a nurse manager that would come and say to me, hey, the patient in 336 rang a call light and I put her on the bedpan, versus the one that will say, oh, 336 is call lights going off. Why hadn't y'all got, So that made a difference because I knew that they wouldn't ask me to do anything that if in a pinch, they wouldn't do. The very first C-section that I was in that had twins. So I'm new twins, and I'm like, oh, this is going to be busy. It's going to be whatever. And it is shift change, So I look up and there standing in front of me is my nurse nurse manager, Kelly Miller, who's still a nurse manager now. I told her if I go back to the floor for anybody, I'd go back for Kelly or April. Those are the only two. But I'm like, what are you doing here? She's like, well, this is your first section with twins. So I'm going to stay until we get the babies together and get them out and make sure everything's good, because I know you haven't done it before. I mean, and she had an hour's drive home, you know?
And see, and you still remember that to this day. I
still remember that. And to this day, if she asked me to come back and work the floor, I would work the floor for Kelly and I would work it for April. Now, my other nurse manager was equally great. I was a new nurse, came in as a nurse extern, as they were called then. And I had to take my boards. And the date that I got was the date I had to work a night shift the night before. And so, you know, when April found out my boards were going to be that Tuesday morning, she called me that Monday and she's like, oh, you can sleep tonight. I said, oh, y'all don't need me? She said, no, I'm going to work your shift.
Oh, wow.
Because you need to be getting good rest the night before board. So I was like, what? You know, she said, yeah, because I want you to get some good rest. I don't want you leaving the hospital to go take your board. So she worked my night shift for me. So that's the leadership that I knew.
Because then you know that your leader truly cares about and your well-being. They do. That's all.
That makes the difference. So I'm going to switch gears for just a moment, because we are here in South Carolina, 2 African-American nurse leaders, right? And so you came from California, which of course has set a lot of hallmarks for nursing. I mean, and they kind of lead the way when it comes to things that we're doing different with staffing and things like that. But nursing in California is a little bit different than nursing in South Carolina, I would venture to say. So how has it been, or how have you adjusted to being here in the Deep South and also being African American in the South? Because I grew up and was born and raised here. So I know that we have some very great people here. There's a richness that's here in all the cultures in the South. But I also know that we also have some issues that we deal with, and that sometimes when the door opens and the face is a brown face, it can bring a different temperature to the room. So how has that been, and how was that adjustment for you?
Well, moving here from California to here, the biggest thing for me as far as transition was more so California was just a little bit more advanced.
Right.
You know, so in a sense, that was actually a plus for me out here, because some of the knowledge or experience that I had, I was able to bring it out here and apply it, or at least address it, with what was going on here. Okay, well, this is how we move forward, or this is what we could do based on some of the experience I had. So in that sense, it was a plus for me. Out here, you kind of like, man, it's kind of slow, but I feel like out here has been such a great opportunity, because I've been able to actually see the environment that I work in just grow and bloom. And that has been rewarding. As far as like, say, being a successful Black woman, it's been challenging only in the sense of sometimes I haven't had to deal with that whole racism per se directly. I may see it around me, but sometimes out here, what I've noticed, and this is just me being honest, is that there's a lot of you're going to have the normal racial disparities that we see. But sometimes the disparities are within our own.
Oh, yes.
And that in itself has been huge for me out here. More so than the typical quote unquote normal racism that we have seen. Sometimes they don't want to, sometimes our very own African Americans may not want to see successful Black women or Black folks, rise to the top. But I've always been one of those individuals, because of the environment that I was raised in California and being so diverse in Southern California. I didn't look at that or focus on that. And I didn't let that hold me back. I feel that most everyone, if you're in the right place, you have the opportunity to grow. You have the opportunity to shine. You have the opportunity to share what your values and what you have and what you can offer to any institution, any job, anything that you're doing. So just being yourself and doing that, and not even thinking into it, just being yourself, I haven't really had a lot of issues with that. And that's honestly, I just go in there, put 110% in, put my best foot forward, make sure that, you know, I come prepared for whatever it is that let's say if I was applying for something, and not look at the person next to me and, well, this person is not the same color that I am. I don't think of it as, well, they're going to get it over me. No, I'm approaching this as I have the same knowledge, the same experience or more, the background, and I'm going to fight for it just as they would. And so that's more so my approach.
That's wonderful. That's good. Yeah, because here in the South, there's a lot of different nuances to things, and lots of times you enter a room and there are heads of departments at the table, and it may be just one or two faces that look similar to yours. But I think when you're someone that clearly is a leader like you, your record speaks for itself. You know, your work speaks for itself, and so does your unit. You know, the people that are there that work for you, and the fact that they want to remain, you know, working for you is really great. How has
that mind? And if you keep that mindset where we're all equal, we're all people. When I cut my hand, the same blood that comes out, color is the same as the person sitting next to me. And you keep that focus on not focus on the disparities. You just focus on what you're trying to gain. You know, focus on you can get there. There may be times you get setbacks or pushback, but don't give up.
Yeah.
Don't give up. You just keep pushing forward.
And having that focus gives you voice, because sometimes if you don't have the focus, you don't want to speak up because you automatically assume that you're not going to be heard. But when you know that you have, you know, valid points and that there are things that we need to do to make change evident, then you can be that person that speaks up. So that's definitely, and I'm sure it's done wonders for the areas where you are. We read in the Johnson & Johnson article about some of the work that you did surrounding staffing and everything when it came to COVID, because I think what happens is sometimes when people aren't healthcare oriented, they don't realize that staffing is an art form. Okay. When nurses staff units and you have these diverse units and you have certain types of nurses that you have to have in whatever areas, you have acuity of patients, you have your ratios of patients, you have the bed board, you know, of the hospital, all of those different things that come into play. How did COVID shift that completely around for you all? And how did you prepare your staff to meet that challenge?
My goodness. So just, you know, I call scheduling a puzzle piece. It is truly a puzzle. And this puzzle, the puzzle's never complete. Okay. Every day you're moving a puzzle piece to a different area because it didn't fit. It's not going to fit that second day or the third day, you know? So when I took on COVID operations, prior to that, I was managing seven different outpatient areas, and then ended up taking on an additional 2 outpatient areas. So that was a total of 9 of the outpatient specialty areas.
Wow.
Got a call or an email one day that said, Tanya, we want you to oversee COVID operations, come up with a schedule, how we're going to schedule this, and move forward.
Wow.
Like, okay. So you kind of just think it out, and I just put it together because being in the predicament that we were in, and of course we had never experienced situation like this before, a pandemic as such, at least that I can remember.
Right.
It's like, first of all, where am I going to get the staff to staff these COVID operations? Because at that time, and it's still the same because we actually have not changed our process, we completely shut down the facility in the sense of we're seeing a few face-to-face visits now, but there were no face-to-face visits. There were no visitors. They could come in, of course, for emergency situations and get to the ED. However, the only entry point to the hospital was the patient entry, unless they were coming through via ambulance. Well, we all know that not everybody is coming to the emergency room comes via ambulance. The majority is they're walking in to be seen for whatever, if their toe hurts, if they're having chest pain, whatever the range is. So we became that entry point, which means I had to make sure I had a level of nursing that was present out there that could critically think, because technically, if you think about it, we then became the ED triage outside, right? With these veterans who are lined up to come in based on whatever it is that they were coming to be seen for, whether they needed to go to the welcome center because they needed to update something. It could be a range of anything. We had individuals that wanted to come in just because they were used to coming in eating in a cafeteria.
Yeah, that's true.
It could be anything. Or you have the chest pain stroke patient that showed up out front because their loved one brought them. So that being said, it wasn't a situation where I could just call in under the nurse manager and say, okay, hey, send me such and such and such. I need 3 nurses, this amount of techs or whatever. It wasn't like that, because they had their own areas to manage and oversee, run, and make the transition that they had to for their own area. So what I had to come up with a puzzle of how would I staff my area safely, effectively. What burden would I put on the employees that were inside running the clinics that we had, whether it was virtual visits or face-to-face visits, and use some of those same staff members and run COVID operations outside. And like I said, I had to ensure that they were clinically competent in a critical environment, because you can see anything that presented out there.
Right.
And so I honestly just went down the list, and I know my employees very well, and I have a good handful of them managing all those areas. I have at least a big pool of employees. And so basically I just looked at my stronger ones that I knew had emergency background or ICU background, or currently worked in an environment that had some kind of critical aspect to it, and kind of brought them forward to be the charge nurse or lead nurses out there, you may say. And in the beginning, we were doing the screenings.
Right.
We were going down the list of questions, of any kind of symptoms. And then we also had the testing area, where if their screening was positive, then they needed to go to step 2 and do a screening and be further screening and evaluation to determine if they needed to get COVID tested, go home, or go to the emergency room. Okay. But they couldn't go into the facility if they were tested. So that evaluation was there. So I was able to get a solid amount of nurses that truly, after I got the lead nurses, they truly just started volunteering. Like, okay, and so I would trial them, and the ones that were volunteering, because I knew them, I knew what qualities and their competency level that they had. And as it got busier, then I would add to that or subtract. It just depended, because I'm staffing now 7 days a week, 11
Wow.
hours.
Oh my goodness.
And we have done that from day one, 7 days, 7 a.m. to 6 p.m. We screen, evaluate, test every single day of the week for 11 hours.
Wow.
What, 19, 20 months, whatever.
Yeah.
Yeah. So, so after mastering that, and I put out a schedule every week, I would start just getting volunteers, even for the weekends. And
wow.
I maybe officially detailed 3 people. Everything else that staffs the COVID operations has been honestly on a volunteer basis. Strictly where I have a volunteer pool where I haven't even had to pull those individuals, or people will show up at my office door like, Tanya, we heard that you run such and such, these COVID operations. We would like to work, or if there's any opportunity or availability, can we work for you on the weekends? Can we work for you during the week? We get off of work at 3:30. We can work from 3:30 to 6. And Lawana, it has just worked. It has honestly just worked. And
I just love nurses. I'm telling you.
And I get out there and I work it sometimes with them, so I know what they're experiencing and dealing with. So I know the days that are heavy days, so I'll beef up staffing.
Right.
Keep in mind who needs to go out on vacation. Like, okay, this one is going on vacation. Let me get another strong suit in so that that nothing stops. It just, the flow is just there. So in the beginning now, when we first started, we started with the testing part inside of what we call the tent. It was ran by the physician.
Oh, okay.
So yeah, because they were doing like the assessment, they didn't put in orders, but they did an evaluation to determine if you had to go to the emergency room or not, or if they would just test and go home. Probably about halfway through, as we started to open up some more clinics, some of these physicians, because they were rotating physicians, maybe half a day or a full day, but we were always at the table or just in communication, just how to make the process better. And it came up like, well, us nurses, let's just say the doctor had stepped out or had to leave early. We saw what they were doing. It's like, we can do this. We're nurses. We assess, we evaluate. So we piloted, we trialed it, came up with the SOP or policy, and came up with guidelines. What guidelines would we follow? What range of vital signs, blood pressure, heart rate, O2 sat, any kind of exposure did the patient have to have in order to be sent to the emergency room? Ran that and collaborated through our chief of cardiology, infectious disease, and some of the key physicians that would be critical physicians that would play a role in that or be able to speak to that, the emergency room docs, and came up with a policy that, okay, here are your guidelines. This is what you do if the patient presents this way. We worked with what we call them CACs, which is the clinical coordinators that work with like the documentation system, and came up with a template for the nurses that pretty much mirrored the physicians or the provider's template, but within the scope of nursing. And it worked. It worked. I mean, it's stepping outside of the box. And as long as you're within your scope, we assess patients every day. It's asking questions. It's looking, how is a patient presenting? Because a lot of times we're the ones that see these patients first before the doc even lays eyes on them. So
you're right.
It was no different. So, we had our, made sure we had everything that was present, O2 tanks in there. We had our vital sign machines. If we had a situation, we'd call the same code if we needed to, whether it's code white or rapid response, whatever. And we just moved forward with it. And we figured there's absolutely no reason to pull a doc or a provider, because it could have been an NP or a PA. So, when they could be inside the hospital seeing clinical patients or doing procedures inside and facilitating that flow while we facilitate what's outside and get them to them inside if needed.
Exactly. That's the business side, because your resources are being used more effectively. It's much more cost effective.
Yeah. And we have not hired any, we haven't hired COVID nurses, COVID techs. The individuals that run the COVID operations are the nurses and techs that are already here that work in our department.
Wow. So that's a beautiful thing. I mean, it's great to see how all of that came together, and also how you being there at the helm made a big difference, in knowing the physicians, knowing who to talk to about the changes you were wanting to make, and continue to keep things going. I know when all the testing and everything really got geared up, you all were doing large volumes, because, I worked I'm an old DHEC nurse too. And I actually went and did some epidemiology investigation type work for them because, I heard that they needed some folks, and I was doing that on the side at home, talking to COVID patients. And I know that y'all had did a lot, of what was done here was actually modeled after the care that the VA was doing and the systems that you all set up, And
we followed those CDC and DHEC guidelines to the T. And it's just, and one of the biggest things that help with the COVID operations is, we have an incident command center, which includes, our PENTAD team, infectious disease, infection control, safety. just building a strong relationship with them. And they are so open to the feedback that we have to give them, myself and my team, and make changes, tweak things, and building that type of relationship in an environment or a pandemic like this is absolutely key.
Yes.
Absolutely key, hands down. Just the support from them and collaboration is what has made us allowed us to be where we are today. March 2020 to
I know.
November
This is a long journey and continuing. You know, the vaccine has changed things, changed the game, thankfully. And I'm glad to see our numbers in South Carolina. We're getting close to, I think we're somewhere between 50 and 55% the last time I looked, you know, at vaccine. Yeah, little by little. But, you know, like I said, we're from the South. You have to have conversations with folks, you know, and you have to be able to do that one-on-one with the patients, you know, and kind of break down some barriers, answer some questions and things like that. So it's good to know that that's happening at the VA, that you all are having that level of care that's there and that expertise that's there for them. So is the morale great, you think, now, or better now with nurses there versus when we were going through all the surges and everything with patient cases?
I think it is. The morale is better. Toward probably the peak of COVID last year, it was difficult. It was difficult. You know, dealing with, you know, individuals being pulled from different departments and being placed in areas that was a little bit outside of their comfort level, to dealing with when they were just dying in our hands. You know, dealing with the families who weren't able to come in and see their loved ones, or had to talk to them through a window, or talk to them on FaceTime. Or, you know, dealing with a CHF patient that we knew for years that caught COVID, complicated, and watched that individual pass away on you. Or our own family members, our own personal losses. You know, we never know what's going on behind when we leave the double doors of this facility in each and everyone's home. So that's what took a toll. It took a toll. You had your days where you're just, I remember there were some days where myself, I would sit there and I'm like, how much more can we take of this? You know, because we know what we know what our profession is. We're going to see death and dying. We're going to see sick people, but to see just how it impacted us, because these patients are our loved ones, you know, because we know what they were going through, especially when we knew, yes, they're sick, but they're healthy sick. But COVID got a hold of them and just took them down. It took a toll. It took a toll. And those are the days where you just had to pull together. There were many tears. Oh, yeah. Tears, long hours, and you just, when is it going to be over? But just pulling together and supporting each other and allowing them to talk, allowing them to shed a tear when they needed to. That's what it takes. That's what it takes. But as we've seen things turn and you've gotten used to, you know, accustom. I mean, there still are tough days. Right. You know, there still are tough days because we still have to, outside of those that are passing away or just being tired, we still deal with the veterans who, number one, may not believe in it. The ones that come in and they're dealing with whatever they're dealing with it at home, or their personal issues, having to mask, having to stand in these long lines, having to get tested, finding out that they have COVID or don't have COVID, especially when they're asymptomatic. You know, there's so many different playing parts in it, but you know, one thing I can say is looking back at it, it's just, you think to yourself like, man, we've made it. We've made it. We're almost through our second year and look at where we are today. And I've told my associate director so many times, I was like, it's almost like the experience has been not fun for what we've seen, but we've enjoyed it. It's been rewarding. It's been a fun experience. Just looking back and smiling and say, hey, if we did this, do anything.
We can do it.
Do anything. And if all you need is that strong team, positive attitude, and we can do it.
Yeah.
Do it.
Yeah. And you all should have great pride in the work you've accomplished in the communities, the frontline nurses and the work that they've done. There's a lot of hope that's there. And the hope is based on the fact that we know that most of the people that are in nursing, we're in it because we love the work. We love the caring. We're compassionate, and we really want to see people, healthier. So I'm really glad to have had a chance to talk with you all and to get to know what's going on. I mean, we're here in Columbia, but there are, even within this community of healthcare, there is different little groups that have things going on. I mean, DHEC has things going on with them. We have stuff going on at the university, your center, things going down in Charleston, upstate. There's so much that's going on just in the state that we don't, sometimes when things like this happen, we don't have the chance to take a deep breath and say, hey, what are you all doing over there? What's going on? How are you? And I think that is one thing I love about COVID, is that it did foster that camaraderie, and there was no let's us get it first, we be the innovators. It was like, look, here's what we're doing, you all need to try this. At the college, the pharmacy school came up with the saliva testing. It was like, great, let's tell everybody. So I love that part of it, that there's a shared experience and everything that's really moved us all forward. It really has.
And I think that this experience has really brought out, it's done both. It's brought out the best in people. Oh yeah. And it's brought out at the same time the worst in people. It really has. And like I said, sometimes you don't even know what you're capable of doing until you're until you have opportunities like this. Not that we want these type of opportunities in pandemics, but it just lets you know how strong you are. What kind of strength you have,
Exactly. That's amazing. Well, I thank you so much for taking time to talk with us. And please express to the nurses that are there. And I say my nursing family because I feel like everybody that I meet that's a nurse, we family, because there are things that you and I know about nursing school and about patients and about being on the floor and about night shift. That's a whole nother level of the family right there. Yeah. So those are things that it's a shared experience. So even though we're not there, we definitely, have prayed for them and thought about them and wanted to do all that we could in the communities to support what was going on there. So we appreciate it so much. And since we are so close, I will have to keep your email handy because I can't say that I might not be working on a project because I'm always working on little things. And I always like to reach out to folks that I know are leaders and innovators and who definitely have their pulse on what's going on here with healthcare in the state.
Please
thank you so much. And please
so much for
we enjoyed it. And please give our love to the nurses there at the VA. We appreciate you all.
Will do.
Take care. Bye-bye.
Bye now.